Good afternoon, colleagues, and welcome to our departmental meeting. So we have our grand rounds with presentations by registrars today. And the first presentation is from the Division of Infectious Diseases. And Dr. Evashan Govender is going to present a case titled A Time Before AIDS. Over to you, Evashan.
All right, thank you, Prof. Let me just share my screen. Okay, good afternoon, everyone. I'm Evashan, and today I'm going to talk about 3 short case vignettes, just to put into perspective the topic I'm going to be discussing today. The first case is that of a 15-year-old girl who was admitted with an acute meningitis. She had a 3-day history of headache and neck stiffness. She had a first sexual partner about 3 weeks prior to admission. She had terminal neck stiffness, and off note, she had bilateral cervical and axillary lymph nodes, together with aphthous ulcers. Her blood work showed that she was HIV positive with a CD4 count of 346, and her CSF results showed a lymphocytic predominance, together with a slightly elevated protein of 0.61. The next case is a 39-year-old male who presented with facial weakness and lymphadenopathy. He presented having a 1-week history of headache and facial weakness. His rapid HIV test was actually negative 3 months prior to presenting. He had bilateral lower motor neuron 7 palsies with shotty axillary lymphadenopathy. His HIV Ellise on this admission was now positive with a CD4 count of 387, and his CSF results showed a lymphocyte predominance with a protein of 0.43. His CLAT and syphilis serologies were all negative, and his HIV viral load showed in the CSF was a log 4.58. This case I actually saw when we were consulted when I was rotating through infectious diseases. It was a 23-year-old lady who was admitted to the G-floor with a meningitis and lymphadenopathy. She had a 1-month history of progressive headaches where she went to a primary healthcare facility. She was screened, had an HIV rapid test that was negative, and was subsequently discharged on just simple analgesia, just for her to represent a few weeks later with no resolution of her symptoms. Concern was that of a meningitis and referred to Prudiskia. And on presentation to Prudiskia, she looked well. She had just shotty cervical lymphadenopathy, which was sub-centimeter with no other focal neurological signs. And at this point, her HIV Ellise was positive with a CD4 count of 477. And yet again, CSF results showed a lymphocyte predominance and negative for CLAT and gene expert. So we assessed my patient as having had HIV seroconversion illness. Her headaches responded well after a lumbar puncture. There were attempts done to do a cervical lymph node biopsy, but that was unsuccessful because of the lymph nodes being too small. An inguinal lymph node biopsy was also going to be done, but that was cancelled by infectious diseases. Given a diagnosis of HIV seroconversion illness, she was started on antiretroviral therapy, and she's going to be followed up at our ID clinic to make sure she's adherent to treatment, and also to watch out for an unmasking TB iris. So essentially, acute HIV infection, also known as seroconversion, is defined as the period between exposure of the virus and completion of the initial immune response. And that's essentially when your antibody tests become positive for HIV. And if you look at this graph, this is your Freiberg staging, which is essentially a 6-stage classification system that was formulated for staging of early HIV infection. And this was based on the different times your viral markers and your host antibody responses start to emerge. If we take a closer look at the immune response to HIV, essentially you get dissemination of the virus to your lymphoid tissues with a rapid increase in your viremia, You get a decline in your CD4 cells with a subsequent increase in your CD8 cytotoxic T cells, which reduces the viral load. You get HIV-specific binding antibodies, and your neutralizing antibodies starting to appear. If we take a closer look at the different stages, the first stage being that of the transmission of the virus, you get activated Langerhans cells, which migrate to your draining lymph nodes for antigen presentation to your CD4 cells. Activated Langerhans cells also produce your pro-inflammatory cytokines like your interleukin-1, 6, and tumor necrosis alpha, which can cause the fever in acute infections. Thereafter, you get the dissemination of the virus, where you get infected CD4 T cells activated in your genital draining lymph nodes, which then migrate to other tissues such as the gut and the mucosa, and associated lymphoid tissues in the skin. Your follicles expand as your B lymphocytes proliferate, and the entire lymph node starts to enlarge. And dissemination of the virus results in increased viral replication, and mainly in your lymph organs. And so the cutaneous immune responses to HIV are thought to cause the maculopapular rash that we see in acute HIV infection. Of note is that the dendritic cells, despite being CD4 negative, can capture your HIV virus on their surface with the CD209 molecules, and also mediates infections of your CD4 cells. The control stage is a stage where we get a robust T cell immunity, where the tissue dendritic cells engulfs the virus detected in your extracellular spaces, and they present your viral peptides to T cells in the lymph nodes. You get a reduction in viral replication due to activation of the CD4 helper T lymphocytes and your CD8 cytotoxic T lymphocytes, which leads to reduced viral replication. However, that response is not sufficient enough to eradicate the virus, but it does reduce the viral load enough to allow the CD4 T helper lymphocytes to increase in numbers. And thereafter, seroconversion. And this is when your antibodies to HIV begin to appear. And this is done by the presentation of your HIV antigens by your follicular dendritic cells in the lymph nodes to the B lymphocytes. So the clinical manifestations of acute HIV infection is vast. Most often patients present with persistent generalized lymphadenopathy, and that is because of marked follicular hyperplasia in response to HIV infection. The lymph nodes are very highly concentrated with the virus. Oral lesions like aphthous ulcers and even opportunistic infections like candida infection can be present. You can get a mobiliform rash. Fever is also presenting a symptom. And neurological symptoms and diagnoses of aseptic meningitis is also quite common. I looked at the study, which was a prospective single-center cohort study of about 290 patients with well-documented primary HIV infections. And these patients were divided into either having typical acute retroviral syndrome, where typical was defined in table 1 as having a fever plus any of the symptoms in table 1, or without a fever and 2 of those symptoms. It was surprising to note that in the study, 30% of the patients presented with atypical symptoms shown in the second table. And of the atypical cases, as you can see, your opportunistic infections accounted for at least 23% of the cases, with your central nervous system and the GI tract being the most affected organ systems. Another interesting finding in the study was that patients with atypical symptoms seem to have been hospitalized 4 times more compared to the patients presenting with typical symptoms. So this study basically shows that unexpected atypical presentations and opportunistic diseases occur in a substantial proportion of patients with primary HIV infection. This was also a very interesting study, which looked at 20 individuals who had acute HIV infection with an average of 15 days after exposure. And they underwent clinical, neurological, CSF, MRI, and MRS characterization, where the HIV RNA was detected in CSF in 15 of the 18 patients as much as early as 8 days after estimated HIV transmission. And most of these patients presenting complaint was just headache with no other neurological symptoms. There have also been a few case reports of facial nerve palsies in acute HIV infection. And another very interesting case report was that of a fatal brain necrosis in primary HIV infection. And in this case report, they told the story of a 31-year-old gentleman who was admitted to the hospital with this bulliform rash, a fever, and pharyngitis, having been involved 2 weeks prior. He had an HIV serology test that was done 4 days prior to his admission. On admission, he was well. He had no neurological fallouts. However, on the third day of this admission, he deteriorated, having a generalized tonic-clonic seizure requiring intubation, and his HIV serology at that point was positive. He had a lumbar puncture done, showing a cell count of 217 with a 96% lymphocytes. His CSF HIV-1 RNA was greater than 500,000 copies. And despite, and this is the MRI of his brain, showing massive diffuse cortical and laminar necrosis. And despite being treated with antiretroviral therapy and steroids, he unfortunately passed away 11 days later. Treatment of acute HIV infection, antiretroviral therapy is recommended essentially to prevent HIV disease progression and to minimize the seeding of HIV into any of the sanctuary sites and to prevent forward transmission of HIV. So the key points with regards to primary HIV infection is that we generally recognize HIV in the setting of opportunistic infections and advanced immunosuppression. But seroconversion illness can present with a diverse symptoms and signs and essentially has the potential to go unrecognized. And that has consequences. It delays entry into HIV treatment programs and increases morbidity and mortality of our patients. So as clinicians, we need to have a high index of suspicion, particularly for patients presenting with aseptic meningitis and unexplained exanthem. Thank you.
Thanks, Evashan, for that superb overview of HIV seroconversion illness. I must confess, I haven't had a presentation on this subject in probably over a decade. Mark Mendelson, would you like to comment?
Yeah, thanks very much, and particularly thanks to Evashan for doing this and for a really great presentation. And I think it's in the key points slide, we tried to bring out why we wanted to revisit this. As you say, you know, we haven't heard about this for quite a long time. And really, you know, these three cases, all from Registrars, demonstrate that you know, HIV seroconversion illness, you know, needs a high index of suspicion, a low threshold for thinking about this. It's a very varied presentation. I mean, you know, 50% or so of patients who are infected with HIV, persons who are infected with HIV, will have some form of symptoms, and it can, you know, really range from the mildest through to what Evashan showed in, you know, perhaps this most extreme example of the focal brain necrosis. And I think, although at Registrars we're usually very good at HIV testing almost all patients, you know, that is not true in South Africa in general, unfortunately. And, you know, we see an awful lot of people with aseptic meningitis, for example, who, you know, have an intraviral PCR, which is negative, and we sort of say, well, we don't, you know, people say, well, we don't really know what happened. But the actual detailed history of potential exposure to HIV is missed. So it's really to, you know, not to show anything terribly complicated, but re-highlight something fairly simple, which I think we need to always keep in the back of our minds. So thanks.
Mark, thank you very much for those comments. I wonder if I can ask you a question. The incidence of HIV is clearly on the decline, but we are still seeing many new infections daily. Why do you think it is that an entity that we use to diagnose with great frequency, we now hardly ever diagnose these days?
I think firstly, people are firstly, the majority of people who present will be presenting at primary care. Nowadays, I think people are far more clued up to this, particularly in primary care, and you're much more likely to have an HIV test in that setting, and therefore, we as in our clinical practice rarely see this. So I think that's probably the main issue. I mean, one of the other things I just wanted to say that from Evashan's presentation, this issue of generalized lymphadenopathy, and we were referred this patient to, with respect to whether an inguinal lymph node biopsy was needed, and really there's this shift in early HIV with persistent generalized lymphadenopathy as one goes through, and there's immune exhaustion and change in lymph node architecture that disappears. So if you have lymph nodes enlargement in late HIV, and particularly if it's asymmetric, that's really the time where you need a very close look at those lymph nodes, and biopsy plays a very important role. But in early HIV with persistent generalized lymphadenopathy, shotty, rubbery lymph nodes, usually it's unusual to get anything from those.
Thank you very much, Mark. So there's a question from Gary. Gary, please go ahead.
Yes, I'd like to echo the congratulations to Evashan for a wonderful presentation. I mean, I think just apropos your last comment, and Tobacco, the sadness has been that the diagnosis of primary HIV infection is incredibly rare in this country. Primary care doctors just aren't attuned to it. It's very, very seldom picked up, and I think that's a pity. And Slim Karim years ago had a cohort of sex workers in KZN where they had primary infection, but really very few people have made the effort to set up surveillance and diagnose it early. And although the incidence is declining in the ART era, our HIV incidence remains extremely high. So the main message really is for primary care to be much more aware than they have been to date. And just to share anecdotes, I've seen the bilateral facial palsy. It's incredibly disabling. Unilateral is more common. And sometimes the meningitis can be quite severe. We've had one or two that looked a lot like TBM, and the only reason we held off was because there was rashes and aphthous ulcers and other things to make us realize that it was in fact seroconversion. But I think a very nice illustrative case series of the more severe end that come to us, but it's a milder end that just gets missed.
Thank you very much, Gary, for those very helpful comments. We still have time for comments or questions in relation to this case. Well, if there are none, I would like to assure people that Professor Mendelsohn is not on some remote island, but still present at work. And to thank Evashan for a fantastic overview. Next, we move to the Division of Clinical Pharmacology, and I'd like to invite Dr. Rephaim Mpofu to upload his slides. The title of his presentation is A New Onset Seizure in Pregnancy. Over to you, Rephaim.
Okay, well, thank you, Prof. And I'd like to welcome you all to my case presentation, which is titled New Onset Seizures in Pregnancy. Our consultant for this case is Professor Mark Blockman, who will be representing the Division of Clinical Pharmacology. And we are also joined by Professor Mushi Machila from the Department of Obstetrics and Gynecology, as they were primarily involved in this patient's management. So our patient for this case is a 22-year-old female who at the time was 24 weeks pregnant at her time of presentation. And she has an obstetric history of being gravid at 3-para-1 with a previous TOP in 2019. Her main presenting complaint is that she had collapsed while she was at home with her mother. And on collateral history, she was noted to complain of sudden onset low abdominal pain before she proceeded to have a seizure. The seizure was generalized tonic-clonic in nature, and the patient did not regain consciousness afterwards. She has a background medical history of asthma, which is controlled on budesonide and salbutamol, and her significant social history is that she had apparently had a disagreement with her partner that morning. So an ambulance was called and she was transported to Victoria Hospital, and upon arrival, she was hypertensive and tachycardic with a blood pressure of 177/80 and a heart rate of 142. And she had a reduced level of consciousness with a GCS of 8, and she was therefore intubated. She had 2+ protein urea on urinalysis, and because of this finding, together with the hypertension as well as the seizures, she was treated for presumed eclampsia and was given magnesium sulfate. She was subsequently transferred to Grooteskier, and upon arrival, she was noted to be agitated and restless, and so she was sedated with morphine and midazolam, and her vitals had improved significantly from her assessment in Victoria, and an ABG and arterial blood gas showed that she had a compensated respiratory acidosis. Laboratory investigation subsequently revealed a mild leukocytosis, as well as a mildly elevated alkaline phosphatase and D-dimer. However, due to the clinical picture, as well as the lab investigations, which were not fully in keeping with eclampsia, as well as this collateral social history, the attending obstetricians requested a toxicology assessment in order to rule out a substance-induced condition. And if you look at the toxicology results here on the screen, you can see that tricyclic plasma concentrations were above 600 nanograms per mil, which is the upper threshold for the assay test. And on urine testing, she was also noted to have positive for benzodiazepines and opiates. Although it's important to note that she had received benzodiazepines and opiates during her acute management, and that may have been the cause of these positive urine results. So for the rest of the talk, I'm going to focus on tricyclic antidepressant toxicity. Tricyclic antidepressants are among the most frequent causes of non-fatal and fatal drug poisonings. And despite that, they're still widely used, even though there has been an introduction of less toxic antidepressants such as SSRIs. There's a wide range of indications for which they're used, from obsessive compulsive disorder and migraine prophylaxis, all the way through to peripheral neuropathy or severe depression. And the main issue around TCA use and toxicity is the narrow therapeutic window. And this is what predisposes the drug to toxicity, especially in overdose and poisoning. And when we look at what we're most concerned with, it's generally the neurotoxicity, but more specifically the cardiovascular toxicity that requires attention. Looking at the epidemiology of TCA toxicity, we see that the patients that are most at risk are those in the young age group, between the ages of 21 to 30, and approximately 60% of that cohort is made up of females, and risk factors include history of substance abuse and psychological stresses. It's found to be the most common cause of death by poisoning in developed countries such as the UK, with approximately 20 to 30% of mortality attributed to TCA overdose. And a study was performed in 2013 at Tygerberg Hospital, where 61 patients where a review of 61 patients that were admitted over the 11 years was conducted, and it was found that there was a mortality rate of just under 5%. When we look at the laboratory statistics of Tygerberg hospitals, as well as the UCT laboratory, we find that approximately 200 to 300 tests are conducted each year, have been conducted over the past 2 years. And the average positivity for toxicity, if you take a plasma level of 300 nanograms as a positive cutoff, then the average positivity is around 20%, with a slightly higher detection rate at the UCT laboratory. So if we look at the pharmacokinetics of tricyclic antidepressants, they're highly lipid-soluble weak bases and are therefore rapidly absorbed from the GIT. And because of this, the plasma concentrations can increase rapidly and deterioration can occur early. They have an intermediate half-life between 10 to 28 hours, and its pharmacologically active metabolite also has significantly longer activity. And at high concentrations, TCAs can actually delay gastrointestinal motility due to their anticholinergic effects. And this can result in the delayed emptying of unabsorbed tablets from the stomach, which can also then cause a late deterioration of the patient's condition. They are metabolized via CYP2C19 and CYP2D6 pathways, and approximately 5 to 10% also undergoes intrahepatic circulation. So if we look at how they exert their pharmacological activity, this is a neurotransmitter synapse, and we can see that tricyclics exert their intended pharmacological activity by increasing the noradrenergic as well as the serotonergic transmission, and this occurs by inhibition of reuptake of these neurotransmitters. But in toxicity, the exaggerated inhibition of this reuptake results in their depletion as they're slowly metabolized in the synapse. And this is what results in the eventual decreased myocardial contractility as well as hypertension. TCAs are also said to be promiscuous molecules, and they interact with many other receptors as well, such as adrenergic or muscarinic acetylcholine, histamine, or even GABA receptors. And when we look at the effects of the alpha adrenergic receptor blockade, for example, we can see that this is how patients can also exhibit signs of vasodilation and hypotension. And then when we look at the muscarinic receptor blockade, that's what's commonly responsible for the anticholinergic toxidrome, which is commonly seen in TCA overdose. The most dangerous effect and the clinical features which we're most worried about is that of cardiovascular toxicity. And this is due to the myocardial membrane stabilizing action of tricyclic antidepressants, which occurs because of inhibition of the sodium channels that cause phase 0 depolarization of the action potential in cardiac conduction. And this results in slowed conduction through the His-Purkinje system as well as the myocardium, and then predisposes one to the ventricular dysrhythmias, hypertension, and AV block that one can see. And if we look at some of the signs that you can see on an electrocardiogram, it's been found that QRS prolongation has been found to be the most accurate predictor of seizures and potentially fatal ventricular arrhythmias. But you can also see some other signs such as sinus tachycardia, which is mainly due to the anticholinergic effect. And you can also see a terminal R wave, which is greater than 3 millimeters on lead AVR. And often, sometimes that might be the only sign you'll see. A patient might actually have a narrow QRS, but you may still see a dominant R wave in lead AVR. And these three signs are strongly suggestive of tricyclic antidepressant toxicity. So when we look at the management for TCA toxicity, unfortunately, the evidence base for its management is not robust, and it mainly relies on low quality data from animal studies, case reports, or uncontrolled human studies. And the recommendations shown here are graded by the level of evidence used, with grade A having the highest level of evidence, down to grade E, which is mainly based on consensus guidelines or expert opinion. And the acute management of a patient with TCA toxicity is largely supportive, and assessment of the airway, breathing, and circulatory status is critical, as patients are frequently obtunded and may require intubation for airway protection and ventilation, and they may also have cardiovascular compromise as well. And if we look, it's important to look for physiological abnormalities, particularly acidosis, which can often have a mixed picture. When you think about acute decontamination, it's thought to have a limited role, but multi-dose activated charcoal has some limited evidence, especially if given over 72 to 96 hours. Seizure control can be done effectively with benzodiazepines, and it's important to avoid phenytoin, as that can exacerbate the cardiotoxicity due to its class 1B antiarrhythmic action. The interventional therapy of TCA overdose is mainly centered around the use of sodium bicarbonate, which we'll discuss in the next slide. But just to note that some patients with severe toxicity may actually have hypertension that is refractory despite receiving fluid management as well as sodium bicarbonate. And these patients may actually benefit from the use of inotropic agents such as noradrenaline or epinephrine, as long as, and alpha adrenergic agonists have theoretical advantages as they can counteract the alpha blockade. So the use of sodium bicarbonate was proposed after the similarities between that and quinidine toxicity was noted, and its benefits were noted. And various potential therapeutic mechanisms have been proposed, of which one of the main proposed mechanisms is that of alteration in pH, which causes an increase in the non-ionized fraction of TCAs. And this reduces the TCA receptor binding that can occur. An alternative theory, which is also based on limited evidence, is that the active moiety might actually be the sodium ions in sodium bicarb. And these are thought that it's possible that they might compete with the tricyclic molecules at the sodium channels. And then other theories have also been suggested, such as correction of metabolic acidosis, as well as inward potassium shifting. But, and its overall effect is likely a combination of these proposed mechanisms. When we look at the indications for sodium bicarbonate, the most well-described indications are that of QRS prolongation and hypotension, but it has also been recommended for use in the event that seizures are present. And so, as we've said previously, there's limited data for the use of sodium bicarbonate, but it is widely recommended and practiced. The most robust data available we have consists of a retrospective review of 91 confirmed cases of TCA poisoning that had received sodium bicarbonate in their acute management. And the aim was to achieve a plasma pH between 7.5 and 7.55. And if you look at the proportions, you see sodium bicarbonate was associated with improvement in hypertension within 1 hour in 95% of hypertensive patients. And it also resulted in the narrowing of a widened QRS interval within 30 minutes in 80% of patients. An important caveat that requires mentioning in the discussion around sodium bicarb use is that plasma alkalization often requires frequent monitoring in order to prevent the development of severe alkalosis, as this can increase the risk of harm. And a case series of 2 patients that had cardiovascular and neurological toxicity from TCA overdose that had received bicarbonate infusions together with hyperventilation was published. And they reported that these patients had initially showed an improvement, but subsequently had a decline in their clinical condition and eventually went into cardiac arrest after they developed ventricular fibrillation. And at the time of death, it was found that their pH values were between 6.66 and 7.66 and 7.83. And this just goes to show that careful monitoring of the pH is imperative, and a target of 7.45 to 7.55 is then recommended. So what other options are there out there? Intravenous lipid emulsion therapy has been described, and this involves the use of a 20% free fatty acid mixture that is used for parenteral nutrition and is also used as a vehicle for propofol infusion in anesthetics. It's also used to manage toxicity of a few drugs, including local anesthetics, beta blockers, as well as calcium channel blockers. And it's thought to work by creating a lipid sink in the intravascular compartment. And this sequesters the drug, this lipophilic drug, and sequesters it and reduces its bioavailability. Adverse effects are uncommon, but can include fat embolism, pancreatitis, or even hypersensitivity. And again, the evidence for its use is limited and mostly consists of animal studies and case reports. So if you go back to the case, our patient had a positive clinical course in hospital. The magnesium infusion was stopped the day after her admission, and she was extubated 1 day after she was admitted. And she was noted to have an improved Glasgow Coma Scale, the level of consciousness, and her ECG also had narrow QRS complexes, and her arterial blood gas status had normalized. She was then assessed by psychiatry and was found to have precipitating factors for an intentional TCA ingestion. And her plasma TCA concentrations were monitored during her course and were noted to be reducing as the days went by, and she was subsequently discharged on day 6. And so our take-home points from this case is that one should have a low threshold for substance-induced toxicity, especially in a patient with features that are atypical or unusual, where no obvious etiology has been found. And another point is that TCA-associated cardiovascular and neurological toxicity are key features which require intervention and can be fatal if not attended to. And importantly, it's important to remember that the evidence for sodium bicarb use is poor, but it is still recommended for use as long as it's used judiciously, and that should then be accompanied with frequent monitoring of the pH. And finally, there is some evidence to show that intravenous lipid emulsion therapy may be effective, but I think a little bit more research is needed before it can be widely recommended. So I just wanted to acknowledge the Department of Obstetrics and Gynecology as well as Stellenbosch University. Thank you for your time.
Thank you very much, Dr. Mpofu, for that wonderful presentation. I'd like to invite Mark Blockman to make some comments.
So thank you very much, Rephaim, for a great overview and a great presentation. And also to our astute ONG colleagues who found that when they looked at the clinical case presentation, that it didn't sit well with them from a eclampsia point of view, and then thought to look for substance misuse or a toxic overdose of a medicine. I think that's a very important take-home message. If it doesn't fit the clinical picture, especially in our province, there's often a substance misuse which has occurred. I think importantly, tricyclics are used outside of depression, and we forget about that. So they're still very much accessible for many other conditions, and so people have access to them. And the epidemiology from our own province has shown quite a few cases of tricyclic overdose. The other issue which was highlighted is the risk of a bezoar, where the anticholinergic activity leads to clumping. Almost what happens in cats is a hairball clumping of the agent within the gastrointestinal tract, and you get slow leaching out. And so we must be careful not to discharge patients home too quickly, because you could still leach out the tricyclic and they could relapse. And then last of all, which I thought was important discussion, was the controversy and the controversial use of sodium bicarbonate, which is the go-to agent with very poor evidence, but it's utilized, and then the risk of over-alkalization. And we thought it would be important to open up that discussion and just get some consensus of what we really do. So thank you very much, Rephaim, and for the opportunity.
Thank you very much, Mark. I'm delighted to see you've brought out the big guns. So I'd like to welcome Professor Mushi Machila to our departmental meeting. And Mushi, I invite you to make some comments.
Yeah, so thanks, Ntobeko. Thanks for the invitation from Professor Blockman, and for that very eloquent presentation from Rephaim. I think, most of the comments have been made by Professor Blockman. And of course, she arrived intubated and ventilated already. And with the epidemiological background, she would have been managed anywhere as an Atlantic, and it would have been appropriate to do so. But of course, although she presented with proteinuria and some evidence of systolic hypertension initially, it was not persistent. And I think that that actually was, preeclampsia is a progressive disorder. And so that raised the alarms to look for other, causes. And I think the penny dropped when her mother was concerned that there was an argument and there was a background of depression. And so that prompted the pharmacology investigation. And just to say that, although I was involved initially, when she essentially presented the latter part of my call, Dr. Zoe Mwambek was much more intimately involved. So I would also like to acknowledge that. But thank you for the opportunity and learning the pharmacology. And I think that's a way of working together, and the collaboration is wonderful. So thank you for that opportunity.
Thanks, Mushi, for those comments. While we've got you on the floor, I wonder if I may ask you to teach us about tricyclic antidepressants in pregnancy.
So you're asking about
the use of these drugs in pregnant patients. Are they safe? Are they contraindicated? Do they have any effects on the developing fetus?
Yeah, so I think so some of course the consent it depends on firstly which trimester the patient is presenting, because you obviously worry about the teratogenic effects and so on earlier on. But you always have to balance in pregnancy, of course, about maternal mental stability versus the fetal risk, and it's something that we always consider, and that there are mostly other options. If you had the opportunity to have pre-pregnancy counseling, or you are earlier on in pregnancy, to actually modulate to much more safer medication. So yeah, I think it's a risk-benefit ratio that you'll always play around with.
Thanks, Mushi, for those comments. Gary, please go ahead.
Hi, yes, just a quick comment. Great presentation, Rephaim, and wonderful example of translational cross-disciplinary care. Just wanted to question the role of serial monitoring of tricyclics. You suggested that they came down on therapy, and would we recommend that surely clinical monitoring is adequate and you would expect the concentrations to drop rather than that one would want concentrations to guide therapy, or is that incorrect? Do we need to monitor concentrations in patients?
Hi, Prof. Thank you for that question. So yes, you are correct in that the clinical monitoring is more important, and that's why I think ECG monitoring is the cornerstone of it. The ECG monitoring will tell you whether you need to increase your therapy or whether your therapy is going adequately. The tricyclic concentrations are not thought to be as predictive for outcomes as the cardiotoxic manifestations which you would find on the ECG. So primary ECG, but if you are maybe worried about bezoar or delayed absorption, as Prof. Blockman has mentioned, then you may want to maybe do it after a few days just to monitor that it's going down.
Thanks. There's a question from Clint Cupido. Please go ahead, Clint.
Thank you, Ntobeko. I'd just like to say that, you know, it's fantastic that this case was presented, because this patient was managed at Victoria Hospital by our emergency team, and I'd really be excited to give them feedback on this case. And just one of the things that we often struggle with is that when we are referring patients, and as this case in particular, patient has been seen along the entire platform from home, secondary to maternity, and then including pharmacology, ensuring that there's feedback to our colleagues, because I doubt that any of us would even have expected that this was actually the reason for this patient's admission to hospital. Thank you.
Thanks very much, Clint, for those important contributions. So I would like us to move to the last case of the day from the Division of Cardiology, and Dr. Ellise Gambahaya, who is a fellow in cardiology, is going to present a case of low-flow, low-gradient aortic stenosis. Ellise, would you like to upload your slides?
Thank you, Prof. Okay. Good afternoon to you all. Today I'm going to present on low-flow, low-gradient aortic stenosis. The consultant on this case was Dr. Cupido. So I'm going to start with a case vignette. The history is of an 82-year-old female patient with a background history of hypertension, dyslipidemia, ischemic heart disease. She had an ST segment elevation, myocardial infarction 14 years ago, for which she received a stent to the proximal left anterior descending artery. She came in complaining of exertional dyspnea with a New York Heart Association functional class of 3 and angina with a CCS class of 2. She complained of pre-syncope but had no syncopal episodes. In terms of the physical examination, she was clinically in heart failure with bibasal crepitations, a raised JVP, and an S3 gallop. However, hemodynamically, she was stable with a blood pressure of 138/71 millimeters of mercury and a pulse rate of 81 beats per minute. She did, however, have features of severe aortic stenosis at the bedside. She had a regular, slow rising and late peaking pulse. Her apex was pressure loaded. Her S2 was soft and there was fixed splitting of the S2. And she had a grade 3/6 ejection systolic murmur had at the right upper sternal edge, and she also had a Gallavagian murmur. So these are her investigations. So her ECG was notable for left ventricular hypertrophy with a strain pattern. Her chest X-ray shows a mildly enlarged cardiac shadow and features of heart failure, bilateral pleural effusions, upper lobe venous diversions. She had a calcified aortic knuckle and an unfolded aorta. We went on to do an ECG, an echo on her, and on her echocardiogram, so the image on the right is the parasternal long axis view of the heart, which shows the left ventricle, the left atrium, the aorta with the aortic valve, and this is the mitral valve. So we can see that the left ventricle is dilated and has reduced contractility and reduced systolic function. She also had a calcified aortic valve with restricted leaflet motion. The image on the left shows her aortic valve in the short axis view. And notable is that she's got a tri-leaflet valve, which is calcified, and there's markedly reduced valve opening. And we went on to measure the gradients across her aortic valve. So what we do is we measure the velocity across the aortic valve, and we are able to derive gradients. And we are also able to derive the area of the aortic valve. So her gradients fell in the moderate range. She had a maximum pressure gradient of 44.68 millimeters of mercury and a mean pressure gradient of 26.50 millimeters of mercury. However, her valve area was in the severe range. So in summary, we had a patient who presented with symptoms of heart failure, angina, and pre-syncope. However, at the bedside, she had clinical signs of severe aortic stenosis, but her echocardiogram showed low gradients with an associated small valve area. So I'm going to discuss low flow, low gradient aortic stenosis. Aortic stenosis is the most frequent valvular heart disease and is the most frequent cause of valve procedure worldwide. And we actually use Doppler echocardiography to assess the severity of the stenosis as well as the left ventricular function. We look at three things. We look at the aortic jet velocity, we look at the mean transvalvular pressure gradient, and we also look at the aortic valve area. Severe aortic stenosis is defined as a peak aortic jet velocity of greater than 4 meters per second and a mean transvalvular gradient of greater than 40 millimeters of mercury, and an aortic valve area of less than or equal to 1 square centimeter. And what is the utility of physical examination findings in the diagnosis of severe aortic stenosis? So the table on the right shows the physical diagnostic features of severe aortic stenosis. So these are the features we all know: a mid to late peaking ejection systolic murmur, heard loudest at the second right upper intercostal space. We also know about the reduced intensity of the second heart sound and a low volume and rate of increase of the carotid pulse. So a clinical prediction score actually predicted that if you have 3 out of these 4 criteria, you are most likely to have moderate to severe aortic stenosis. The absence of a murmur at the second right intercostal space ruled out significant aortic stenosis. However, a caveat: in elderly patients with vascular disease, a softer murmur intensity and normal carotid upstroke does not rule out the diagnosis of severe aortic stenosis. In this case, the only finding which would reliably rule out severe aortic stenosis is a normally split second heart sound. So in summary, we can trust our physical findings in predicting the severity of aortic stenosis. So our patient had a low gradient on echo. So this brings into point the phenomenon of low gradient aortic stenosis. Low gradient aortic stenosis is defined as an aortic valve area of less than 1 square centimeters. However, the mean gradient is less than 40 millimeters of mercury. And depending on the left ventricular ejection fraction, you can classify low gradient aortic stenosis to classical low flow, low gradient aortic stenosis when the ejection fraction is less than 50%, which is what we are focusing on today. Then there are other forms of low gradient aortic stenosis, which include paradoxical low flow, low gradient aortic stenosis, and normal flow, low gradient aortic stenosis. These 2 subtypes of low gradient aortic stenosis occur in patients with left ventricular ejection fractions of greater than or equal to 50%. So I'm just going to take us back to look at the aortic valve. So this is a pathology specimen of an aortic valve. So on the right here, we see a normal aortic valve in its closed position, and on the left, we see a normal aortic valve in its open position. So an aortic valve consists of 3 leaflets, which are thin and are very mobile, and the normal aortic valve area is around 4 square centimeters. It's important to note, and this is where the concept really comes, a valve opens when its leaflets are not restricted and when the left ventricle generates enough flow to open it. So you need a valve which has non-restricted leaflets and a left ventricle which is functioning well to generate enough flow so that the valve may open, which will influence the area of the valve. So in terms of the pathophysiology of low flow, low gradient aortic stenosis, it follows that if you have an increase in the flow rate across the aortic valve, you get an associated increase in the valve area. However, if you have a reduction in flow rate, for example, that occurs in patients with reduced systolic function, you get a reduction in the transvalvular gradients because the pressure is directly proportional to the velocity, which equals flow. And if you get a reduction in flow rate, you can also get inhibition of valve opening, which leads to an underestimation of the valve area. So you get a low flow, low gradient state, and this makes the quantitative assessment of aortic stenosis a challenge. So how do we overcome this challenge? We do what's called a dobutamine stress echo to assess the severity of aortic stenosis. So you can have true severe aortic stenosis, where the valve is actually the problem and not the myocardium. And then you have pseudo-severe aortic stenosis, whereby the flow generated by the heart is insufficient to open the valve fully. So we give dobutamine, and dobutamine is a positive inotropic agent, and it increases the contractility of the myocardium. As it increases the contractility of the myocardium, it increases stroke volume, cardiac output, and hence flow across the valve. So with increased flow, the valve is still severely stenosed in patients with true severe aortic stenosis. However, the gradients increase. However, with pseudo-severe aortic stenosis, with increased flow, the valve then opens, the valve area increases and the gradient remains constant or just drops slightly. It's important for us to differentiate true severe aortic stenosis from pseudo-severe aortic stenosis because the management is very different. In patients with true severe aortic stenosis, these are patients who benefit from aortic valve replacement. But those with pseudo-severe aortic stenosis need to be managed for heart failure with reduced ejection fraction. So this is just a representation of what of a patient of what we actually do when we do a dobutamine stress echo. So what we require is that the patient needs to stop beta blockers 2 days before, and for the test to be valid, we look for a 10% increase in heart rate, and we give incremental doses of dobutamine. So we take an echo at baseline, and we repeat our echoes as we increase the dobutamine dose. And we look at the ejection fraction, we look at the contractility of the myocardium, as we also measure the pressure gradients across the aortic valve. And in a patient like our patient, in this example, who has true severe aortic stenosis, you can see that the velocity increases with incremental doses of dobutamine. And the mean pressure gradient also increases with increasing doses of dobutamine. And this is an example of true severe aortic stenosis. So back to our case. So this is the echo, which shows the baseline from before dobutamine. So this is an apical 4-chamber view and looking at the zoomed in view of the left ventricle. And we can appreciate that the contractility of the left ventricle here is reduced before we give dobutamine to the patient. And then we also measured pressure gradients across the aortic valve before we gave dobutamine, and we can see that the mean pressure gradient was 25.74, which is way below the 40 millimeters of mercury, which is required to make a diagnosis of severe aortic stenosis. However, the aortic valve area was 0.6 square centimeters. So this is our, again, our apical 4-chamber view focusing on the left ventricle at the maximum dose of dobutamine. And we can see there's increased contractility of the myocardium. And these are measurements of our gradients and our valve area after at the maximum dose of dobutamine. And we can see that the mean pressure gradient went up to 53.5, which is in the range of severe aortic stenosis, but our aortic valve area remained the same at 0.6 square centimeters. And these two correlate. So a low valve area with a high gradient across the aortic valve, giving a diagnosis of severe aortic stenosis. So our final diagnosis was low flow, low gradient aortic stenosis. And in our patient, we referred the patient for aortic valve replacement, transcatheter aortic valve replacement versus surgical valve replacement. And in our patient, we felt that because of her age and her comorbidities, she was a suitable candidate for a transcatheter aortic valve replacement. Unfortunately, this was complicated by complete heart block, which is not uncommon, and she was given a pacemaker, and in her last follow-up, she was doing well. So the take-home messages are that, number one, clinical signs are a reliable indicator of the severity of aortic valve stenosis. So do not ignore your findings at the bedside. And the Doppler echocardiography is a primary modality for the assessment and follow-up of stenosis severity and left ventricular function. So patients who are suspected to have aortic stenosis should be referred for Doppler echocardiography. Transvalvular gradients are not a reliable indicator of aortic valve stenosis, of the severity of aortic valve stenosis in the setting of a low flow state, as occurs in patients with a reduced ejection fraction. And aortic valve area gradient discrepancy raises uncertainty about the stenosis severity and should be investigated further by imaging, especially in the form of a dobutamine stress test. Thank you.
Thank you very much, Ellise, for that fantastic presentation. You know, I still get very excited when I see pictures of the heart. I'd like to invite Blanche Cupido to make some comments as the consultant.
Sure, thank you, Ntobeko, and thank you, Ellise, for that presentation. Ntobeko, you are most welcome to come to the echo room any day you want. There are a couple of things I'm going to mention because this to me is a very important thing in that we don't miss a structural heart disease and we get them timeously so that we can intervene. One of the things is important to note is that when you have a patient with a clinical heart failure syndrome as well as an echo and you notice that the patient has a murmur and you have clearly demonstrated that they do have heart failure, the important thing is to actually refer them for a cardiac assessment rather than merely ask for an echo. And the first reason I say that is because there are caveats where echo can let us down and where pitfalls in the reliability of echo sometimes prevents patients from getting to us timeously. And this is an example of that. If I have a patient who has heart failure and severe aortic stenosis at the bedside, and my echo comes back saying that my gradients are not severe, that shouldn't deter me from referring the patient on. And the reason for that is we've now mentioned the caveats. There are a couple of things. Firstly, aortic stenosis can sometimes be very difficult to assess in that you don't align the Doppler probe properly and you don't get the correct gradient, and so you may undercall the gradient, and most of the time you call it less than it actually is. So that's the one thing. The second thing is, if the patient for another reason has a sort of flat ventricle that's not generating enough flow to open the valve, when you have a ventricular or muscle problem, replacing the aortic valve is not going to make your patient better. In the same way, if you then have a low gradient and you think the patient doesn't have severe aortic stenosis, but actually you could have generated a better gradient if you gave dobutamine, that's someone who would have benefited from an aortic valve replacement. So this is a very important distinction for us, and it's got a lot of prognostic influence. So the main thing is to see, is it a muscle problem or is it a valve problem? And dobutamine helps us here. So if we give dobutamine and we then generate enough flow to be able to open the aortic valve and the leaflets are then still not opening, then we know that it's definitely a valve problem. But if we give the dobutamine and we see that the ejection fraction goes up and then the valve opens beautifully, then we know that it's a muscle problem, and in that case the patient doesn't need an aortic valve. So the main take-home message, I think, for the physician at the bedside is that if you have a patient who at the bedside has heart failure and who has clinically severe aortic stenosis, so they've got low volume pulses, a slow rise and fall pulse, and you hear the murmur and S2 is soft, even if your echo then comes back as a low gradient, you still have to refer to consider that patient, because it could be someone who falls into this category, and that has got massive prognostic benefit for the patient. So don't throw out your clinical evaluation merely based on a potential low value that you may get on an echo report. Thanks.
Thank you, Blanche, for those very clear points and take-home messages. There's a question in the chat function, and I wonder if you can respond to it, asking about the relationship between aortic stenosis and mitral incompetence linked to flow of blood.
Okay, so it's important to know that the butamine stress echoes and the concept of low flow, low gradient aortic stenosis has been described in the literature as aortic stenosis being a primary and a singular valve pathology. Remembering that we have a very different group of patients to what they have in Europe. In Europe, most of the time, the aortic stenosis is related to degenerative disease, and in that case, it will be a single valve pathology. When you add multiple valves, it is very difficult to differentiate out the components. So if I have mitral regurgitation, I cannot really truly assess my flow state across the aortic valve because half of my cardiac output is going back into the atrium. So in that case, this particular scenario of doing a dobutamine stress doesn't hold true. And what we would do in that case is to do a full heart study where we measure the pressures across all the different valves, as well as look at the contribution of each of the valve lesions to what happens in the ventricle. So everything in the heart, essentially the thing that dominates wins. So if my mitral regurg is dominant, I'm going to have a volume loaded ventricle. If my aortic stenosis is dominant, I'm going to have a pressure loaded ventricle. So it becomes a very tricky assessment in the context of multiple valve disease, and it's not as straightforward. I would not do a dobutamine stress echo in the context of mitral regurgitation because I would not be able to differentiate the contribution of each valve. And I would use different modalities such as TOE or cardiac MRI in that case. Yeah.
I think you've answered the final question from Tony, the finding of a small valve area and the diagnosis of this condition. I think both you and Ellise have addressed it, but I wonder if you want to make a brief comment.
Sure. So look, that's actually part of the whole definition of when we would do that. Essentially, the finding a low valve area means my valve hasn't opened. And my valve doesn't open either because the leaflets are restricted or because my ventricle's not generating enough pressure to open it. And that is where dobutamine can differentiate the two. If I give dobutamine and my valve then opens up, then I know that it's a muscle problem. But if I give dobutamine and my valve still doesn't open up, then I know that it's a valve problem. And so the definition of low flow, low gradient AS will be the group of patients that has a low valve area, but has a mean gradient that doesn't correlate with it.
Well, thank you very much, Blanche, and congratulations to Ellise for a superb presentation. I think you must agree with me that all three of today's presentations were of a very high standard, and congratulations to all of the presenters. So colleagues, it's a pleasure to end today's meeting and to wish you all a wonderful evening. Take good care. Bye.